This patient is clearly symptomatic from her disease, and the question is, not whether or not you're going to treat her, but with what? What is the best option for her? And I think we have data from the COMFORT-2 study that can help us in that decision. The COMFORT-1 study, just to remind you, was a study of ruxolitinib, the JAK1, JAK2 inhibitor, versus placebo. Well, I'm not going to dwell on that study because in that study, some patients didn't receive anything. In a patient who has constitutional symptoms, symptomatic from their splenomegaly, I think most of us would want to treat that patient. In COMFORT-2, which was a study that was done in Israel and Europe, patients with intermediate to and high-risk myelofibrosis, either primary myelofibrosis or following prior polycythemia vera or ET, were randomized to get ruxolitinib at a dose of 20 milligrams twice daily if their platelets were above 200,000, or 15 milligrams twice daily if their platelets were between 100 and 200,000. They were excluded from the study if the platelets were below 100,000. Patients were twice as likely to get that than the control arm, which was best available therapy. Patients who received best available therapy, most of them received hydroxyurea, some received the immunomodulatory agents like lenalidomide or thalidomide, steroids have been used, and interferon as well, if I didn't mention that already. And so there was a crossover in the study. The primary endpoint was at 48 weeks control of the splenic volume, or reduction of splenic volume as measured by MRI of more than 35% in that reduction in that volume. The primary endpoint was met. None of the patients in the best available therapy arm actually achieved that endpoint, and it was 28% of patients at 48 weeks who actually had a 35% or more reduction in splenic volume with ruxolitinib. A key secondary endpoint was control of symptoms, which is important to consider in this patient who is symptomatic with night sweats and weight loss and the abdominal fullness. In that study, approximately 45 to 50% of patients had a 50% or more reduction in a total symptom score that had been validated previously in patients with myeloproliferative neoplasms such as myelofibrosis. Even when you consider each of the individual symptoms in the total symptom score, night sweats, pruritus related to cytokines, weight loss related to cytokines, but also symptoms related to the spleen, early satiety, abdominal fullness, pain under the ribs. Patients had the same type of benefit from ruxolitinib in all of those individual symptoms. So I think in a patient like this who is symptomatic, I would start with ruxolitinib. Her platelet count is 189,000. I would start, the label dose is 15 milligrams twice daily. Quite frankly, I often start lower, but remember to escalate the dose as tolerated every 4 weeks. Now, there was another benefit that was seen in that study. Another key secondary endpoint was survival. Now, one of the problems with evaluating survival in this study, and as well the COMFORT-1 study, was that it was a crossover design. And if patients had progression of splenomegaly or an increase in the requirement for opiate analgesics for control of painful spleen, they could actually cross over. And in fact, in the COMFORT-1 study, at a median of 9 months, patients crossed over from placebo to ruxolitinib. In the COMFORT-2, at a median of 15 months, they crossed over, most of them crossed over from best available therapy to ruxolitinib. However, when you evaluate survival at 3 years and now at 5 years on that study, even though there's a crossover, there was a trend for an improvement in survival. The p-value at 5 years was 0.06, but there was a trend for an improvement in survival with about a 35% reduction in the risk of death in that 5-year follow-up of the COMFORT-2 study. And so in a patient like this, you're not only trying to control symptoms, you're not only trying to control the spleen, which you can do with ruxolitinib, but you are also trying to extend survival. But let's not forget that, ruxolitinib so far has not been clearly shown to change the natural history of the disease. We have not been able to show, because of the crossover, honestly, in these studies, that there's a decrease in fibrosis. It complicated that analysis. Although you could see some decrease in the allele burden of the JAK2 missense mutation, it's not been dramatic. And so it's not clear that ruxolitinib really changes the natural history of the disease. And so in a patient with high-risk disease, she only has hypertension. If her spleen is controlled, she gains weight, she improves performance status, this is somebody that I would definitely still consider for allogeneic stem cell transplant as the only potentially curative option. And so that's something we shouldn't forget about in our patients with intermediate 2 and high-risk disease, that a potentially curative option that can actually reverse the fibrosis is allogeneic transplant.